Hello, everybody. Welcome to the PrecisCa Hematologic Malignancies Tumor Board. Very happy to have you here. Very excited to go through some of these really interesting cases. The cases that we are going to focus on today are all patients with various forms of lymphomas. We have an outstanding panel with us here today to go over these cases. I'm very excited to be amongst them. I'm going to first introduce myself. I'm Dan Pollier from the University of Colorado, and I'd like each of my colleagues to introduce themselves. Dr. Fromm, please.
Hi, my name is Tyler Fromm. I'm an assistant professor of radiology with appointments in abdominal imaging and nuclear medicine at the Washington University School of Medicine in St. Louis, Missouri. I specialize in oncologic imaging with a focus on MRI and PET examinations.
Larry Keston. I am a radiation oncologist in Michigan, in the Detroit area. I work for Michigan Healthcare Professionals and Genesis Care USA. I'm the medical director of the Michigan region.
Hi, I'm Jeremy Abramson. I am a medical oncologist specializing in lymphoma. I direct the lymphoma program at the Massachusetts General Hospital in Boston, and am associate professor of medicine at Harvard Medical School.
Hello, good afternoon. John Pagel. I am the chief of hematologic malignancies and the director of the stem cell and cellular therapy program at the Swedish Cancer Institute in Seattle, Washington.
This is a 39-year-old male with stage IIIAX, classic Hodgkin lymphoma, nodular sclerosis type, who has completed 3 cycles of a planned 6 of a course of doxorubicin, vinblastine, dacarbazine, and nivolumab. This regimen has been complicated by hypothyroidism, and the patient is now presenting for consolidative radiotherapy. So the main question to answer here is, given the hypothyroidism, should proton therapy be offered for this patient, with the caveat that the patient lives quite far away? But before we dive into that very interesting question, because we have multiple cases here of Hodgkin lymphoma, I just want to establish a couple of facts here for our audience. And Dr. Abramson, maybe can you just briefly take us through the staging system for Hodgkin lymphoma?
Sure. The staging system for Hodgkin lymphoma is based on the number of nodal regions involved, as well as whether there's extranodal involvement, whether there's a presence of B symptoms, and the presence of bulky disease. And so stage 1, Hodgkin lymphoma, is a single nodal region of the body, or a single localized extranodal location. Stage 2 would be multiple lymph node regions on the same side of the diaphragm. Stage 3 would be lymph node regions involved on both sides of the diaphragm, and would be considered advanced stage. And stage 4 would be extensive involvement of an extranodal location, such as the bone marrow, liver, etc. So stage 3A disease denotes disease involving nodal regions on both sides of the diaphragm, as well as the absence of B symptoms. And historically, the X moniker added to it denotes the presence of bulky disease.
That's great. Thank you so much for orienting us. And then, Dr. Pagel, do you mind, we're specifically told that this is a nodular sclerosis type of Hodgkin lymphoma. Do you mind just sort of telling us a little bit about the different subtypes of Hodgkin lymphoma? There will be a couple of different ones as we go through, but if there's any significance in your mind of this subtype in this case before we go any further.
Yeah, I think, Dr. Pollier, that it's important to understand that there are 2 big classes, so to speak, of Hodgkin lymphoma. They're either, of course, what we would call classical Hodgkin lymphoma, and the histologic subtypes thereof are really all in the same category where nodular sclerosis lives. It's the most common histologic subtype of classical Hodgkin lymphoma. And importantly, we differentiate those classical Hodgkin lymphomas from a very distinct separate entity we call lymphocyte predominant nodular Hodgkin lymphoma. It's a very different entity. It's actually much more like an indolent non-Hodgkin lymphoma. It's much more like a follicular lymphoma or a small lymphocytic lymphoma. Lymphocyte predominant Hodgkin lymphoma isn't really a Hodgkin lymphoma. It behaves in a fashion that's slow growing. It's often treated very conservatively, like we would treat a follicular lymphoma. It's also very important to understand is that we don't cure those typically with standard therapies like we would a classical Hodgkin lymphoma, like nodular sclerosis, classical Hodgkin lymphoma. And that's what we're talking about. And it's very important to understand the differences there, because not only are the prognoses very different. Classical Hodgkin lymphoma, nodular sclerosis, as in this case, is highly curable in in the majority of patients, depending on their limited stage or advanced stage, as Dr. Abramson just described. And that's very different than what we have with the lymphocyte predominant Hodgkin lymphoma, where it's more of an indolent disease. We don't commonly cure the disease. And because of that, also, it's important to recognize that our treatment approaches, our therapeutic interventions are very different. One is with curative intent. It's with the regimen that you mentioned that we commonly use, ABVD for nodular sclerosis, classical Hodgkin lymphoma. That's very different than how we might approach someone with this more indolent LP Hodgkin lymphoma, where we might just use something like single agent rituximab.
Great, thank you for that. And we will have a case coming up where that subtype is relevant. So let's just look at the patient's presentation. So remember, this is a 39-year-old male, and original presentation was with an enlarging left neck mass for 6 months. This is a patient with a good, with no real comorbidities, a good performance status, ECOG of 0. No significant medical history. Social history is really non-contributory, and no hematologic malignancies in the patient's family history either. So when we focus on the oncology history, so this was January 2020, a left neck lesion was noted, and as we heard before, there was a 6-month delay before seeking attention. And you can understand based on these dates the reason for that. I think this is sadly, even in the best of circumstances, something that we in the oncology field deal with is people that have to or do delay their therapy for a variety of reasons. But the worldwide pandemic was another major contributing factor to people delaying attention to things like this. I don't know, Dr. Abramson, is that something that you've seen in your clinic over this past year? And are you, is this something that you are concerned is going to be catching up with us in the near future?
We've certainly seen delays to diagnosis. I think it's been, patients have been hunkered down. They've been avoiding hospitals, which they associate as having potential exposure to COVID. And of course, a lot of ambulatory offices and practices have had more limited access and volume. We're relying purely on virtual care. So I think we are seeing delays in diagnosis and potentially presentation at more advanced stages than we'd seen otherwise. It's worth noting that advanced stage classical Hodgkin lymphoma is a highly curable disease. Thankfully, Hodgkin lymphoma has a very high cure rate independent of stage. But that said, we always prefer to diagnose earlier. And I think the pandemic has certainly impacted that across the board.
Yeah. So, and I think that's what we see in this case. The mass became painful, which, you know, is not typical with the presentation of Hodgkin lymphoma. These usually painless masses, and, you know, they usually, you know, often get quite large before causing pain. And at that point, underwent workup. Biopsy of this did reveal the classic Hodgkin lymphoma, nodular sclerosing type, positive for CD15, CD30, MUM1, and DIM-PAX5. So he then had a staging PET scan, and we'll go through those images in a moment. Actually, Dr. Fromm, do you mind just taking us through, sorry, the pre-treatment imaging that we can see here? I think you're on mute there.
Sorry about that. Yes. So on the images on the left-hand side, we have 3 transaxial fused PET CT images through the neck and thoracic inlet. And what we see are multiple hypermetabolic lymph nodes involving the left cervical chains as well as the left supraclavicular region. On this scan, the thyroid gland appears normal. We're also told that there was possible splenic involvement. We don't have any images showing that, but probably what was seen was that the degree of the radiotracer uptake or FDG avidity within the spleen was probably somewhere, potentially similar to the liver or slightly above it.
That's great. And Dr. Pickle, is that a classic sort of radiographic or clinical presentation of this disease? I mean, in terms of the lymph nodes involvement in a lot of the same neighborhoods, or do you typically see more widespread disease at diagnosis?
Well, of course, it could be either situation. We often with patients who are different than this with what we would call limited stage disease, stage 1 or stage 2, again, where disease might be above just the diaphragm. It's not uncommon for us to see just disease in the chest or not, and that it marches along relatively slowly from lymph node groups locally or regionally, but again, on the same side of the diaphragm. When you start talking about advanced stage disease, which we have here, stage 3 or even stage 4 disease, it can present in a variety of ways that can be, of course, a very aggressive presentation. So you can see patients with lymph nodes in multiple locations, as we have here. Sometimes you can even see, of course, big bulky masses in the abdomen that can be particularly problematic for patients. And not uncommonly with advanced stage disease, you can see, at least in about a third of patients, significant extranodal disease, which was alluded to earlier. So it might be extensive osseous involvement that can happen. You can see these PET scans where there are multiple lesions that are lit up in lots of places, the so-called kind of Christmas tree appearance that can be really high risk and raise a lot of concern for a practicing oncologist, but still recognizing that there's an extremely good chance that you can cure even those types of advanced stage patients.
Great, thank you. And then, so this patient would start on a regimen of doxorubicin, vinblastine, dacarbazine, and nivolumab. And as was referenced or alluded to earlier, one of the most amazing, incredible stories of oncology in the last 50, 60 years has been the dramatic outcomes that we have seen in Hodgkin lymphoma and the very high cure rates. And as we'll talk about in a few moments, a lot of that is because of the combination of chemotherapy and radiation. But Dr. Abramson, can you just tell us that, this regimen, is this a standard regimen? Is this a regimen that is commonly used in the upfront setting with the incorporation of nivolumab? And can you just comment on what the typical standard approach to this patient might be?
Sure. Actually, this is not a standard regimen. And I wonder if this patient was actually treated in the context of an ongoing clinical trial. But there are really 2 standard regimens, and nivolumab is not considered a component of upfront standard therapy at the current time, though it is clearly a highly effective and available option in the relapsed and refractory setting. Our most commonly used regimen initially for advanced stage or limited stage Hodgkin lymphoma is ABVD, adriamycin, bleomycin, vinblastine, and dacarbazine, which has been a long-standing standard of care, a highly effective and overall well-tolerated regimen, though it does include bleomycin, which carries with it a low but potentially serious risk of lung toxicity. More recently, there was a randomized trial called the ECHELON trial, which compared standard ABVD to brentuximab AVD. And in that regimen, the bleomycin was substituted out for brentuximab vedotin, which is an anti-CD30 antibody drug conjugate, another targeted therapy that previously had been FDA approved for relapsed Hodgkin lymphoma. So this clinical trial compared ABVD to brentuximab AVD It found a modest improvement in progression-free survival, favoring the brentuximab arm, but with no improvement whatsoever in overall survival. The arm of brentuximab AVD also had significantly increased toxicity, including an increased risk of peripheral neuropathy, as well as an increased risk of neutropenic fever, infections and fevers occurring in the setting of low blood counts that prompted mandated inclusion of a white cell growth factor to support that regimen. Most of the benefit was seen in sort of younger, higher risk patients. So I'd say still today, I use ABVD as my standard approach in the vast majority of advanced stage Hodgkin lymphoma patients. But for an advanced stage patient who's young and has a number of high risk features, they have stage 4 disease, for example, they have extranodal involvement, they have presenting with other high risk features like anemia or hypoalbuminemia. In those patients, I may very well consider brentuximab AVD. But really, those are the two options. I'll note that the reason I suggested this patient may be treated on a clinical trial is there is a current randomized clinical trial occurring in the US intergroup, which is comparing brentuximab AVD, the regimen I just mentioned a moment ago, to nivolumab AVD. So while nivolumab is not currently a standard of care, it is being explored in the setting of a clinical trial. And so based on the results of that trial, it may become a standard option in the future.
That's great. Thank you for that overview. And so we're then told that this patient's course has been complicated by hypothyroidism, and I'm assuming that the implication is that the hypothyroidism could be due to the nivolumab, which, as you said, Dr. Abramson, is an accessible therapy, typically in the relapse setting, and is being explored in the upfront setting. Dr. Pagel is a real expert in immunotherapies. And can you just give us an assessment, Dr. Pagel, of what the complication rate with respect to autoimmune complications that we have from drugs like nivolumab, and then also maybe just tell the audience a brief summary of the mechanism of nivolumab.
Well, sure. Of course, this nivolumab is from a class of drugs that we call the checkpoint inhibitors. The checkpoint inhibitors have been also game changers for patients with relapsed Hodgkin lymphoma, just like brentuximab vedotin has been as well. We have two major approved checkpoint inhibitors for relapsed Hodgkin lymphoma to date. One is nivolumab, another one is known as pembrolizumab. They're both highly efficacious agents, used as single agents often in relapsed patients. But as Dr. Abramson mentioned, they're certainly being explored as well in combination therapies. You heard about the combination of nivolumab with AVD here. Also in relapsed patients, we're actually even looking at those kinds of combinations for those patients, and even combinations without any standard cytotoxic chemotherapy for patients with Hodgkin lymphoma. Even looking at agents like nivolumab in combination with brentuximab vedotin, no chemotherapy for older patients who are treated in the front line where they may not be able to tolerate chemotherapy. So these are important agents, nivolumab and pembrolizumab, the checkpoint inhibitors. And of course, what they are also well known as are PD-1 inhibitors. Remember that there's an interaction between Hodgkin lymphoma cells and the patient's own T cells through a axis known as the PD-L1, the PD ligand 1, and the PD-1 antigen receptor interaction. That interaction actually is a mechanism for the malignant cell to turn off the cytotoxic T cell and to keep it from killing that cell. So the simple way is to think about it is that it's a way to put the brakes on the T cell through this interaction between PD-L1 and PD-1 between the malignant cell, here we're talking about a Hodgkin lymphoma cell, and the patient's own cytotoxic T cells, which we would hope would be able to control disease, maybe even eradicate it if it were to rear its ugly head in some ways. So that's been an incredibly powerful technique for us to exploit, recruiting the patient's own immune system cells to, in a novel way, fight the disease. of course, when that happens, we're activating these T cells as well. These T cells are the most powerful immune system cell that we have in our body, and they're not only powerful toward the malignant Hodgkin lymphoma cell, but they also can then be activated and cause some havoc, so to speak, with our own normal tissues. And so you will see immune-mediated, T cell-mediated cytotoxicities of normal tissues, and that can manifest itself with things like hypothyroidism. It certainly could be pneumonitis, inflammation, or an inflammatory reaction in the lungs. And it could be even more difficult things in treating sometimes, such as things like uveitis, an inflammation in the eye, or transaminitis, some inflammatory reaction of the liver. Fortunately, most of these things are highly reversible, but you have to stop the drug. You have to pay attention to it and really expect it and know that. And also sometimes you need to treat it with some anti-inflammatory type therapy to dampen down the effect of those T cells. And that might even be with some steroid use. So this is a not uncommon, albeit recognized problem that we can see, hypothyroidism as an example, with these PD-1 inhibitors or checkpoint inhibitors like nivolumab.
Just listening to you talk, it's striking how, the history of Hodgkin lymphoma is the history of oncology. Having an incurable disease that some of the first chemotherapeutics were used to cure the disease, combined modality therapy, bringing in radiation oncology for the first time, one of the first times with this disease, and now, these kind of science fiction therapies going away from chemotherapy entirely. It's just an incredible story, and obviously it's the patients who have benefited from all of these advances. So just moving along, Dr. Fromm, maybe I'm going to go back to the next the follow-up post-treatment PET scan, and maybe you can just take us through that.
Sure. So on the right side of the screen, we have 3 transaxial fused PET CT images through the neck and thoracic inlet. And what we see is the sites of really hypermetabolic lymphadenopathy in the left neck and supraclavicular region. Those sort of bright spots in the images on the left have really gone away in these images that we see here. Now we're told the patient had a Dovel 3 scan, which means that there was still some sites where there had been disease initially, where there was a little bit of that radiotracer uptake, but it was sort of on par with what we see in the liver, and that usually means that we've kind of gotten to the point where we would call it potentially a complete metabolic response to therapy. We do also see some sort of new mild activity within the marrow of the upper extremities. And that could perhaps be related to the patient having received some sort of colony stimulating factor in the interim during chemotherapy. And then really sort of the striking finding and kind of the crux of this discussion is that we see this new diffuse hypermetabolism or increased radiotracer uptake within the thyroid gland. Now, lymphoma can occasionally involve the thyroid, but usually, this thyroid gland itself will be enlarged, and that involvement, will tend to be sort of more asymmetric. In this case, this is kind of the classic picture that we see for thyroiditis on a PET CT scan, and we actually see a new lymph node on the right side of the neck, at the level of the thyroid cartilage there, that's a little bit hypermetabolic, which presumably would be a related, a reactive process related to the active inflammation in the thyroid gland itself, rather than a site of lymphoma involvement.
And I am a leukemia person in my day job. So can you just briefly go through the Deauville criteria? You mentioned that a Deauville, some evidence of residual activity. Can you just, for the audience, orient us a bit on that the different levels?
Sure. So the Deauville criteria are also sort of called the 5-point scale, depending on the center where you're being treated. And essentially what it is, it's a standardized system that radiologists use when reading PET scans on patients that have, most types of lymphoma. And essentially what it is, it's using an internal reference within the body to judge how active the cancer is. So we have 5 tiers, 5, 4, 3, 2, 1. And when we say that a patient has a score of 5, we're saying that a site that we believe to represent lymphoma has activity or takes up the radio tracer to an extent that's sort of markedly greater than that of the liver. So the liver is kind of an important internal reference. When we say that there's a score of 4, what we mean is that there's a site that we believe to be lymphoma that has activity that is mildly greater than the liver. And both of those categories, when we use those categories, we're saying that we think there's still residual metabolically active lymphoma. When we use the category of 3, we're saying that we see a site where there, once was disease, but now has sort of uptake really only similar to that of the liver. A 2 would be similar to a site of disease with uptake similar to that of the blood pool. And a 1 would mean that basically we don't see any residual uptake above that of the background tissues. And generally, when we call something a 3, 2, or 1, we're saying that we think there's probably no residual active lymphoma. So, oftentimes sites of lymphoma will not entirely resolve on CT images or MR images. There'll still be some residual soft tissue there, but as long as the activity on the PET scan within that tissue is sort of similar to the liver or lower, we tend to think that means that we have what we call complete metabolic response to the treatment.
Thank you very much. That'll help us not just for this case, but in the further cases. Okay, so Dr. Keston, thank you so much for your patience. Your role in the care of these patients is so critical in terms of being able to have the high success rates in curative therapies. So this is the patient now, has completed 3 cycles, has this interim PET scan that looks quite good, but he has developed this complication with the hypothyroidism. They have a specific question about proton therapy, and I'd love your thoughts on that, if there's a role for that in this disease. But can you just in general give us a sense of, if this patient had been treated with a standard upfront regimen, what would the radiotherapy course look like at this point, if any, and take us through the thinking there?
Sure. So radiation therapy is most commonly given for Hodgkin's lymphoma in the early stage setting. So stage 1 or 2 disease, as Dr. Abramson lined up earlier. For stage 3 and 4 disease, it's a more widespread problem, and so the primary treatment is typically systemic therapy, drugs that Dr. Abramson and Pagel were already talking about. In this particular setting, this patient had bulky disease, and so it would be very reasonable to add radiation treatment to the site of bulky disease in this particular scenario. Radiation therapy in general is handled as an outpatient, Monday to Friday, 5 days a week for a few weeks, sometimes as little as maybe 15 treatments, as many as 20, I guess even less sometimes in the setting of lymphoma. And so radiation for us in radiation oncology, those are relatively lower doses compared to the doses that we tend to give for certain other malignancies. The radiation treatment is local treatment. There are x-rays that only go exactly where we aim them. And so the only place where you can have side effects are where the x-rays are aimed. So in the setting of this particular toxicity that we're talking about, hypothyroidism, then obviously, that would only occur with radiation treatment if we hit the thyroid with the x-rays. So we have to do everything we can to try to avoid, hitting the thyroid. And in this situation with stage 3 bulky disease, we would be aiming at the bulky disease itself. I'm not sure exactly where that was in this particular case. Maybe maybe we're calling it the left neck area. The left neck imaging that I saw did not look like what I would classically call bulky, but we would aim at that location. Let's just assume for the sake of purposes in this particular instance that it was in the left neck location. Obviously, that is going to be very close to the thyroid, and so it's going to be more difficult to avoid the thyroid with the X-ray beams in that particular situation. Proton therapy is a more recent option that has become available that functions similar to X-rays when it comes to curing cancer, including lymphomas, but adds an additional dimension of, with it being a charged particle, of stopping at a certain depth. With X-ray or photon beams, with standard radiation treatment, those beams can be shaped and aimed at a particular target, and that shape is quite accurate with X-rays, photons, and also with protons. But the depth of the X-ray, the depth of the dose delivery with standard X-rays occurs along the path of the beam. And so the way we get around that problem is we deliver the X-ray treatment with a lot of different beams from a lot of different angles. And there's some fancy techniques for that, which we could talk about later if you want. With proton therapy, the same type of beam shaping can occur, but you can also control the depth a little bit more. And so it gives you an additional dimension potentially of control where you might be able to avoid the thyroid a little more in this particular instance. You could certainly compare a proton plan to a photon plan for this particular case. My guess is that you would probably be able to avoid the thyroid reasonably well with a photon plan, but a proton plan could be somewhat superior. For hypothyroidism in general, it's not something we would typically make major treatment decisions about because it's a very easily treated problem, with thyroid replacement therapy. But certainly we want to avoid any side effect that might ever occur with hypothyroidism from radiation treatment. Most of the literature is based on different types of cancer, like head and neck cancer, where the doses of radiation treatment are much higher than that used for lymphomas. And in those settings, with higher doses, hypothyroidism can occur about 25% of the time. In general, one tries to keep the region of the thyroid, the volume of the thyroid, to less, that is receiving radiation treatment, to less than 30 gray, a certain dose of radiation, or keep a mean dose under 25 gray. So there's certain parameters that you can control to avoid hypothyroidism. My guess is one could easily meet those criteria with a photon plan, but one could always compare it to a proton plan and see if that were superior.
Great. So thank you so much. So I think, take home points from this case would be, a patient such as this should be treated in a way that would have the potential for curative therapy. The incorporation of radiotherapy to bulky areas after chemotherapy is appropriate. It's still the standard of care to give an ABVD regimen, or perhaps in some situations, brentuximab instead of the bleomycin. And if one is going to do radiation, it could perhaps be safe in a lot of ways to do standard photon radiotherapy and avoid the thyroid, or accept that there would be some toxicity which would require thyroid replacement, but it would not be unreasonable to investigate whether this could be done with a proton facility if it were feasible. So that's great. Let's
Dr. Pollier, can I just make one comment?
Please.
Yeah, the other comment I'd make about that patient is I actually would not recommend radiating that patient at all. In advanced stage disease, as Dr. Keston pointed out, the real bulk of the work is the systemic therapy because it's a systemic disease. And I agree with Dr. Keston's assessment of the imaging. I didn't see any bulky disease there. Bulk is often a term used conventionally, but it actually has pretty clear definitions. And in Hodgkin lymphoma, it's been defined in the United States typically as 10 centimeters. In Europe, it's been often defined as 7.5 centimeters or above. We saw nothing approaching that on the imaging. But even if we had patients who achieve an interim PET complete metabolic response, which is what Dr. Fromm showed us, those patients do extremely well with systemic therapy alone and without consolidative radiation. And in a 41-year-old patient, we'd also be thinking about potential long-term risks for somebody with decades of life expectancy ahead. So this is a patient who had an interim PET complete response. I think they're likely to do extremely well with systemic therapy alone.
And would you give more systemic therapy then?
6 cycles total.
Oh, okay.
Great. Yeah, maybe Dr. Pollier, I'll add on to, of course, what Dr. Abramson added there. I completely agree with his thoughts. I guess I would say my hunch is there was maybe a bulky mass down lower that we didn't get a chance to see, or perhaps. But nonetheless, I think what's really important is that this is not something that we would treat with radiotherapy. And I would also point out that there was that lymph node that was near the thyroid that Dr. Fromm mentioned that might be reactive to the hypothyroidism. You know, we'll see things like that. And I think one of the most important things you can say here is that we should never assume, if we can, that anything we see on interim PETs or even PETs at the end of therapy are true positive cases of ongoing Hodgkin lymphoma, where we would certainly recommend that you need a biopsy of these types of things to make decisions about continuing or changing treatment. So that lymph node that was near the thyroid that was new, it's likely reactive. I completely support that. But if you were worried that was Hodgkin lymphoma, you'd want to biopsy that to make sure before you would want to do anything different with your treatment. My hunch is that this patient's going to do very well. But I would also point out we don't really know at this point. I mean, Dr. Abramson might agree with me about what the interim PET means in patients who get nivolumab with ABVD. That's why it's part of a clinical trial. And typically we do those PET scans after 2 cycles and not after 3. I suspect that this patient here we see a negative PET after 3 cycles of therapy will suggest and predict that this patient will likely be cured, but we're still waiting for that data in this novel regimen as well.